Hello everyone, I'm Dr. Aanchal, and in this session we'll be learning about the Part B anatomy. The topics will be from the upper limb, the important ones like the brachial plexus, the nerve injuries like Ups palsy and the Klumpke's palsy, and along with that we'll be covering few small topics like cubital fossa, anatomical snub box, and the wrist joints. Okay, so let's start with first the nerves of the upper limb. Okay. From this section, they'll first show you an image. The brachial plexus will be there, or some markings will be there in the anatomical cross sections or anything. And they'll ask you about the branches from which supplies what and everything. So I'm not going deep into the brachial plexus now because it will itself take a lot of time. So you have to remember the brachial plexus branches from the roots, the trunk, and the cords. The division has no branches. You have to remember all the branches. And in this session, mainly I'll be teaching you about, or I'll be explaining about the injuries like your Erb's palsy and Klumpke's palsy because the questions are mainly from that area. Okay. So first is the Erb's palsy. What is the nerve root injury or what is the nerve injury here? It involves the root values of C5 and C6. The upper half, you can say the upper half of the brachial plexus, C5 and C6. Primarily three nerves are injured, main two and one is minor. The two main nerve injury is axillary nerve and musculocutaneous nerve. Along with that, there is also involvement of the radial nerve. Okay, so if what are the first we will see everything in anatomy. First we will go in stepwise manner. So first in the axillary nerve, we will see what is its function. So if the axillary nerve is damaged, what will be the resulting findings? So axillary nerve, what does it supply? It supplies the major muscle that is the deltoid. And what is the function of the deltoid? It does abduction, your overhead and the 90 to 120 degree, sorry, 15 to 90 degree, but your abduction is done. And another function of the axillary nerve, it also supplies the sensory supply over your regiment badge area. Okay, let's first see the uh, functions and then we will go into the findings. Okay, if it is injured, then the musculocutaneous nerve. What does it supply? It supplies three major muscles, that is biceps, brachialis, and coracobrachialis. What is the collective function of these muscles? They help in what? Flexion, and supination. So if that will be gone, the resulting finding we will see. And what is the major function of the radial nerve? It helps in the extension at the wrist joint. Okay, so let's see now what happens in this Erb's palsy. If these three nerves are injured, for example, first the axillary is injured. So deltoid is gone, then the hand abduction won't be possible. So hand will remain in adducted position. Okay, first finding is gone. Then the second musculocutaneous nerve. It supplies the biceps, brachialis, and coracobrachialis. Collectively, they will do what? Flexion and supination. So if these functions are lost, what will be the resulting finding? The hand will be extended and in pronated position. Okay, so first we have seen it will be adducted, then the second we have seen it will be extended, and then the third it will be pronated. Then the third finding, what happens if the radial nerve will be injured? The extension at the wrist joint won't be there. What will be there? Resulting finding, flexion. So how the final hand position will be there? This is adducted, then extended at the your elbow joint, extended, pronated, and there will be flexion at the wrist joint. Okay, so this will be your policeman teeth deformity, or you can also call this Potter's tip hand. Okay, so very easily you will first see what the nerve is doing, and if it is injured, what will be the resulting finding. Okay, adducted, extended, pronated, and the flexionist wrist joint. Okay, then next nerve injury, that is the Klumpke's palsy. What happens here? This is that was in the upper half of the brachial plexus. The injury was there. Here the injury will be in the lower half, that is C8 and T1. So mainly which two nerves will be injured? That is your median nerve and the ulnar nerve. Okay, so what is the function? What are the functions of the median and the ulnar nerve? They collectively supply the lumbricals and the interossei muscles of your hand. Okay, so if the lumbricals are gone, what are the functions of the lumbricals? They do what? Flexion at the metacarpophalangeal joint and extensor at the interphalangeal joint. So if the nerve is lost, this function will be lost. And what will be the resulting finding? There will be extension, hyperextension at the metacarpophalangeal joint and flexion at the here what? Interphalangeal joints. So this is what? Your claw hand. Okay. Now here comes one important point. The examiner might ask you, apart from these hand findings, what are the findings? In apart from the upper limb, you can see in Klumpke's paralysis. Okay, so what happens? Here it is involved C8 and T1. This T1, it also is a part of the sympathetic plexus that is supplying your face. So if the T1 is lost, Then there will be one syndrome called Horner's syndrome. What is the triad of the Horner's syndrome? You have to look that. What is this? Ptosis, meiosis, and hyperhidrosis will be there. Okay, so apart from the upper limb findings, if there is Klumpke's paralysis, there can also be Horner's syndrome. Okay. Then another question from this part, what about the ulnar paradox? What happens? The ulnar paradox says the higher is the injury, the lower will be the clawing of the hand. How will that be? If the higher is the injury, then the supply to FDP, it will also be lost. So the clawing will be lost. So the lower the injury, the FDP is spared, clawing will be more. Okay, this is your ulnar paradox. This is your ulnar paradox. Ulnar nerve injury at the wrist, there will be more clawing. Okay. And if the injury is at elbow, higher injury, the prominent claw will not be there. Less prominent claw will be there. Okay. Then at first topic that is about those nerve injuries we have done. Then the second is about your wrist joint. They usually show you this X-ray picture and they'll ask to name all the wrist bones, the carpal bones. Okay. And they'll ask other questions apart afterwards. Okay, so what are the carpal bones? We all know the mnemonic. C looks too pretty, try to catch her. So from the distal row, the proximal row, you don't have to answer in the exam that mnemonic and all those. You will answer in such a way that like the proximal row contains this four from lateral to medial, and the distal row contains this four from lateral to medial. This is the list. Okay, so the proximal row contains what? Scaphoid, lunate, triquetral, and pisiform. Pisiform is your what? Medial one. Okay, and the lateral one is scaphoid. From the scaphoid, lateral to medial, it is scaphoid, lunate, triquetral, and pisiform. In the distal row, from the lateral to the medial, it is trapezium, trapezoid, capitated, hamate. Okay, now here what will be the question? It will be about the scaphoid bone, the blood supply of the scaphoid bone. Okay, so what is the blood supply of the scaphoid bone? It is from the palmar-carpal branch of the radial artery. What is the peculiar point here? It is a retrograde supply. What happens? The artery arches around and first supplies the distal part, then the middle part, then the proximal part. So if there is any injury around there and the artery is crushed, then the distal and the middle part may be spared, but there will be avascular necrosis of which part? The medial part. Sorry, the proximal part. Okay. So it receives the blood supply from the palmar-carpal branch of the radial artery. This provides an abundant supply, okay, but it neglects the proximal portion. So if there is any injury, there will be AVN of the scaphoid bone in the proximal part. Okay, now comes the Allen's test. We all know why did I add Allen's test? In the exam, the question will flow in this manner. Here you are saying about the palmar-carpal branch of the radial artery. We have mentioned about some arterial supply. Then they will go into the Allen's test of the arterial supply. Okay, so what is Allen's test? It is done to test what? The patency of the radial and the ulnar artery. So alternatively, we will press one and release one, and we will see if there is any pale or whitening of the palm is there. Accordingly, we will see if there is any blockade or any problem is there with the radial or the ulnar arteries. Not. Okay. Then the next topic is about your anatomical snub box. Okay, this is a very frequently asked question about the anatomical snub box. They will ask you about the anatomy, the boundaries of the anatomical snub box, the floor, the content, and the clinical significance. So let's first see the boundaries. So the lateral boundary or the radial boundary is formed by what? Abductor pollicis longus and extensor pollicis brevis. And the medial boundary is formed by extensor pollicis longus tendon. Okay, in the content we have what all things? In the content, we have radial artery, the radial nerve, the cephalic vein, and also we have two more muscles that are morely on the floor of the anatomical snub box. What are those two muscles? Extensor carpi radialis longus and extensor carpi radialis brevis. Okay, what is at the floor? Mainly the clinical significance lies around the floor, base of the anatomical snub box. Here we can see one bone, scaphoid. So if there is any pain in the anatomical snub box area, what will be the clinical finding here? It can be due to the fracture of the scaphoid bone. So we cannot miss this. If a patient is complaining about pain in the scaphoid in the anatomical snub box region, then we have to do an X-ray of the wrist bone and check if there is any fracture of the scaphoid bone, because this can easily lead to avascular necrosis of the proximal part of the scaphoid. Okay. What is the significance of the anatomical snub box? Just now we discussed about that. What does tenderness at scaphoid mean? This can be due to scaphoid fracture. Okay. Now the last part of this series, this discussion, this is about the cubital fossa. It is a very easy topic. They can show you a cadaveric image of this cubital fossa. Still, it's very simple. We have to learn the boundaries of the cubital fossa, the content of the cubital fossa, and few significant clinical significance around it. Okay, so what is the boundary? The lateral boundary is formed by what? Brachioradialis muscle. Okay, the medial boundary is by pronator teres medial head. Okay, and then the base or the upper boundary, it is formed by an imaginary line connecting the lateral epicondyle to the medial epicondyle. So all the three boundaries, it's done: lateral, medial, and the base. Okay, now comes to the content. The content is very easy. If we have done our MBBS, then we by now we know the mnemonic MBBS. From the medial to the lateral, the four contents of the cubital fossa, they are: first your median nerve, then B is for brachial artery, another B, that is biceps brachii tendon, and the S, it is S for superficial branch of the radial nerve. Again, we will revise this. The content of the cubital fossa from the medial to the lateral, MBBS. Okay, median nerve, brachial artery, biceps brachii tendon, and the superficial branch of the radial nerve. Okay, we have seen the boundaries, we have seen the content. What is its anatomical significance? When we draw blood, that venous sampling we are doing, we usually take the blood from the which vein? That is the median cubital vein. What is the reason that we take this take sampling from this vein? There are two reasons. Very first, it is superficial, so easy to take. Second is it has support. If we are piercing any vascular structure, then we will have to see if there is any support around that or not. Okay, so what happens? This median cubital vein, it rests on aponeurosis. What is that aponeurosis? That is bicipital aponeurosis. Okay, so if we are piercing, there is a support, so less chances of getting collapsed or damaged. Okay, so from which vein we take the sampling? That is from the median cubital vein. Why? Because it is superficial as well as it has a support in the form of bicipital aponeurosis. Okay, we have learned the boundaries, the contents, and the clinical significance. Okay. This was a very short discussion, and this is it. We have learned about the nerve injuries, the Erb's palsy and the Klumpke's palsy, the Euler paradox, and then we have learned about the bones of the wrist joint, significance of the scaphoid bone, then about the anatomical snub box, what is the clinical significance of pain around the anatomical snub box, then we looked into cubital fossa. That's it for today. Thank you. Thank you so much.